Bismillahirrahmanirrahim. Assalamu alaikum. On behalf of the Sindh Institute of Urology and Transplantation, I would like to welcome you to this special webinar to recognize and understand the scientific contributions of Professor Muhammad Mohiuddin in making animal to human organ transplantation, cross-species or xenotransplantation, an actual possibility in the future. By overcoming long-standing scientific and medical barriers, Professor Mohiuddin and his team have actually made this possible to have a animal heart beating in a human chest and sustain life, demonstrating real possibilities for animals as a source of replacement for organs for humans who need them. Dr. Mohiuddin has not only advanced science and medicine, he has also brought laurels for his alma mater, Dow Medical College, and for his country of origin, Pakistan. SIUT celebrates that. Today, Dr. Mohiuddin will be talking to us about his 30 years plus of research in cardiac xenotransplantation, how he got where he is and where the field is right now, and what's ahead for him and for his field. So, Professor Mohiuddin, since the day the news broke of the successful experimentation with cardiac transplantation, our director at SIUT, Professor Adib Rizvi, has been extremely keen on engaging with you. And his preference, of course, was physical presence. However, given your current work commitments, Dr. Rizvi has settled for this virtual meeting to start off with. I would now request Professor Adib Rizvi, the director of SIUT, to say a few words of welcome to our distinguished speaker. Professor Rizvi.
It is a great honor to have you here, sir. We are honored that in spite of such a busy schedule, you have taken time off and you are giving this talk. There's a lot of things have happened during a few years, but something which has brought honor to the nation, encouragement to the younger generation is your work. And we're extremely thankful. And we pray Almighty that you should make progress further and more and more. The only request I would like to make is that you should take some time off, if possible, to visit personally to this country. And we are very keen to receive you here. And that will be great encouragement to our younger generation. We want to show that in Pakistan, there are people who are doing good things as well. We want to show to the nations of the world that we are not only bad people as pointed by the press. We have got intellectual, we have got selfless workers, we have got those who are going to change the fate of the universe by their research and their hard work. So my request will be that if you have got any plan, any visit this direction, please let us know. I would like to receive you.
Thank you. Thank you, Dr. Adib Rizvi. It's indeed a great honor for me to be here. When Dr. Rizvi asked me to join, there was no question of me saying no. I have such a great respect for Dr. Rizvi, and he's one of my idols, and I'm sure idol of many of the people sitting here. So. We look up to his achievements, and whatever I have done, it's because of role models like Dr. Adib Rizvi. If I could share my slides, I will. So thank you again for this opportunity. I'll take you back not 30 years, but at least 15 years of research that led to this transplant. It's been like a roller coaster journey. And as you know, the research is never rewarding all the time. You know, there have been times that there was time of despair and frustrations, but you know, there have been times where Allah subhanahu wa ta'ala has rewarded me tremendously. So I mean, this is a long journey. What we have achieved now, honestly, I never imagined that we could have done it in, at least in my lifetime, because of a lot of negativity surrounding this field. And you know, the progress that was very slow, and all the experiments have been very, very expensive. So as you guys know, the reason we are doing xenotransplantation is because there's a large number of patients now waiting for an organ transplant, and no matter what we do, how much awareness we will create, this list will not go down, and most of these patients you know, die waiting for the transplant, as shown here. And this is data from United States, and you can multiply it by several hundred folds when we talk about the entire world. So based on this data, one person every 80 minutes is dying just waiting for this transplant. So the one option for this is xenotransplantation, which is not new. It has been tried for the first time in 1682 when a nobleman lost his piece of skull, and a piece of dog's skull was transplanted to save his skull, and that was done successfully. Later on, you know, several burn patients received frog skin to repair their burnt skin. But in the recent years, if you remember, and some of us may remember this, the baby heart was the most famous in 1984, when this heart was transplanted by Leonard Bailey in Loma Linda, and this heart survived for 3 weeks. This is perhaps the longest xenograft ever survived, and this heart came from a baboon. Along with Leonard Bailey's, Keith Reemstema did kidney transplants in 1963, even before I was born. And James Hardy also did chimpanzee heart in 1964. In the recent times, Tom Strazel did a liver transplant, but none of these survived for a long period of time, because most of these were done without long research and without proper data. Just it was a last ditch effort to save the patient's life. So I mean, you know, we suggested that we should use pigs instead of baboons for several reasons. I mean, when I say I refer to a large number of people who have been working in this field for even longer time than I am. So the pigs were chosen because of their ability to genetically modify them. That we know the genome very well now. We have techniques to modify their genes. They are anatomically similar. Their organs are anatomically similar to humans and baboons, which we used as the recipients in our preclinical studies. They are farm animals. They breed well in captivity. They have a quick breeding cycle. They attain required size within months. And in large part of this world, they are consumed in food as food, and there are less ethical issues because of that. So, and their physiology, as we are learning, is very similar. There is some differences in the heart rate and a few other things, but overall, the physiology is very similar. So what happens if you take a pig heart and transplant it? in this case, in my initial studies were to transplant them in the abdomen with leaving the original baboon heart and just transplanting this heart in the abdomen to see the effect of various genetic modifications and also different immunosuppression. So when you transplant an unmodified heart and without any immunosuppression, this is what happens. So within minutes, the heart looks like this, and it rejects very quickly with what we call hyperacute rejection. And what we found in the vessels is like there was microvascular thrombosis that happens very rapidly and causes it to reject. And the other findings include, loss of myocytes and bleeding within the interstitial spaces. So what happens? One of my colleagues, Uri Galili, several years ago discovered that millions of years ago, the old world monkeys, apes, and us have lost this enzyme. Let me just get the, so if you can see my cursor, so lost this enzyme due to some calamity, and because of that, we stopped having this sugar on our endothelial cells, which lines the blood vessels. Because of that, we develop antibodies against these antigens, and when we transplant this baboon heart, baboon organ, and the vascular system comes in contact with this these antibodies, it causes the endothelial cells to swell up, expose lamina propria, and then causes rapid coagulation and thrombosis of the vessel, in the vessel, and then leading to the death of this organ. So, I mean, over years, we started to find different reasons for these for the rejection, and I describe it as the process as an onion. As we started peeling off one layer, we started discovering other issues, and all these years, our focus was to get to a stage where we can comfortably say that we have dealt with major issues, if not all. So in my research, my first success came in. So until 2001, the survival was very difficult. In 2001, if you remember, just before 2001, they discovered this technique of cloning, and the first dolly sheep was made, and the same company then knocked out the carbohydrate that I showed and the enzyme from the pig cells, so that don't express that carbohydrate, and therefore the antibodies we produce do not cause rejection. So with that, using that animal and another gene, CD46 transgene, we for the first time showed that a long-term survival about 230 days was achieved. This was also achieved by using the immunosuppressive regimen, which I'll talk in a little bit in detail later on, requires elimination of B cells with rituxan and using a co-stimulation blockade antibody. In this case, we used anti-CD154, which is also called CD40 ligand, and we got survival. Until this time, the longest survival used to be 180 days. We got about 250 days. So that was the first success. But later on, we got about like a year survival, which was considered a milestone. And then we found out that this anti-CD40 antibody that we were using was causing its own complication and was causing thrombosis in the animal, so by itself, because it is expressed on platelet and causes platelet aggregation. So with that, we switched to CD40, which is the same, which is the antibody that blocks the same co-stimulation pathway, but on the other end. But when we used the same dose of that antibody, we were not able to survive, to get the long-term survival as described here as in the green. However, when we doubled that the dose of that antibody, which we later found out that was due to the instability of this antibody, we were able to get survival for long period of time as shown in red. So throughout my career, I've kept my regimen the same, with which I'll describe in a bit. And with this regimen, we were constantly now getting long-term survival beyond years. So this is the regimen that we finally started using, and a lot of people call it Mohiuddin's regimen, but I have not called it Mohiuddin regimen yet. So this includes induction with a couple of doses of anti-thymocyte globulin to remove T cells, and 4 doses of Rituxan over a period of 3 weeks, and also we use different agents to block complement, either the cobra venom factor or recently C1 esterase inhibitor. Our maintenance is predominantly with anti-CD40 antibody and MMF, and we taper down the steroids and stop them within 2 months. We give some supportive treatment. This is all baboon work. We give heparin continuously throughout the period of survival, and to prevent CMV, we give ganciclovir. So this is the mechanism that we targeted the most. So as you know, that antigen presenting cells express CD40, and then the T cell express CD40 ligand. Our goal is to stop or prevent this interaction. But in xenotransplant, as the main culprit is the antibody-mediated rejection, our main target is stopping the B cell activation, and also stopping its help to the T cell. And in that way, we are stopping T cell activation also. So both these pathways that I'm showing are blocked by either CD40 or CD40 ligand, which I've used before. So this was one of our seminal papers that showed that we can get long-term survival of cardiac xenograft in the abdomen, but when we started to decrease the dose of this anti-CD40, still we got the good survival until we thinking of tolerance, we completely removed this antibody, and we found out that these hearts rejected as soon in a couple of months after removing this antibody, when all this antibody was washed out of the system. So this histology is just before around like 2.5 year time period. This is a biopsy specimen. It shows that it didn't have any signs of rejection. So this was like our proof of concept that with this model we established that we can avoid xenograft rejection. We have a genetic platform that we can use for the pigs, and we have an immunosuppressive regimen that is effectively working in a xenotransplant model. So this is just to show that how the survival went. I started my research in 1991 until we started. I started at NIH, the large animal model, in around 2005. Until that time, the survival was very little, less than 100, most of the time, 1 or 2 going over 100. But since we started, we slowly, all this work is my work in our lab. We've slowly showed progress of survival, and finally the longest survival ever for up to 3 years. So now the logical next step was to transition and to see if this heart that that is not rejected in the abdomen could support life. And for that purpose, we transitioned from an abdominal model to an original orthotopic model where we took out the baboon's heart and transplanted the pig heart. Unfortunately, that transition was not smooth as anything in research. Any change is not always translatable. So our initial work had a lot of hurdles. All the hearts within 48 hours started to fail. But on histology, they don't look like that they were rejected, but there were some other mechanism that they started to just run out of gas, basically. So while we were doing all these transplants, we also continue to manipulate the genetics system of the pig. And this is not done at our lab. It's done with in collaboration with a company called Revivicor, which is a subsidiary of United Therapeutics. This is the same company that cloned Dolly sheep in England and known to be PPL when it was acquired by another company here at in the United States. It was called Revivicor. So just for people who are not familiar with how these genetic modifications are done, here you can see that what is done is you take out the eggs from the ovary, from the ovary, and then you take out you suck out the genetic material from those eggs. And then you have a construct of the desired genetic material developed outside the body, and then you insert that genetic material into the eggs, and then put the eggs back into the ovary. And after like 114 days of gestation, new pigs are born, which have the new genetic material. Then the next step is to see whether the genes you desired are expressed or are deleted. So on the left panel, the flow cytometry is showing the blue. The pink ones are in a naive pig versus the blue one is showing that all these 3 genes were deleted. And then you see the expression of the human transgenes that we express, and you can see it with the Western blot in the column D, and also you can see on immunohistochemistry. So this is just to verify that what we wanted is in there. So these are some of the genes that we have modified. We found out that there are like 3 carbohydrate genes that are immunogenic to humans. So we have knocked them out. As you may know, that the pigs grow very fast. So there was a concern and some evidence that the heart or other organs, especially kidney, that can grow fast in another species also. So for that matter, we knocked out this growth hormone receptor gene to control the growth. So to make it the pig still grows, but at a very slow rate. Then we focused on several other genes. Some of them, the HO1 is an anti-inflammatory gene. The HLA-E is also a kind of anti-inflammatory. We put 2 transgenes to suppress the complement activity, CD46 and CD55. Then we also found out that there's some incompatibility between the human and pig coagulation systems. So we put a couple of human anticoagulatory genes like EPCR and TBM. So as I mentioned, our initial success was very limited, and all these hearts start to fail within 48 hours. At that time, one of our German colleagues in Munich discovered that this solution, which is at that time called Steen solution, which has all the electrolytes, hormones, and other inotropes, and on top of that has cocaine in it, is a good preservation solution. And if you preserve the heart with this solution, you can overcome that 48-hour failure, which we termed as perioperative cardiac xenograft dysfunction. So the heart is taken out, put in this machine that we are the only one who have this machine in the United States, but it's used clinically in Europe. And you preserve the heart for an hour to 90 minutes with continuous perfusion with this solution that also include blood, and then you transplant the heart, and then you know, we have not seen any failure from that point on. So this is just a heart, if you guys could see, just after transplantation in the chest, and it functions very well and continues to function for a long period of time. So this is some of the recent results. As you can see, each step, you know, it was very progressive from orange to purple to blue to green and finally red. So there was a progress in survival based on various things, various genetic modifications, as you can see. So that the pigs that we are using right now have 10 gene modifications, the same gene that is used in Mr. Bennett in human, which has 4 knockouts and 6 human transgenes. And we have seen progressive improvement of graft function and longevity after these modifications. Although we have kept our immune suppression exactly the same as I described. So there was no change in immunosuppression, and and we got survival based on different gene modification. So, I mean, you know, this was a famous quote of Thomas Starzl, which kept me going, that, you know, history tells us that procedures that were inconceivable yesterday are barely achievable today and often became routine tomorrow. So that was my goal, to see the xenotransplantation becomes a goal. This is my team, the lab team. So the story doesn't end here. So this is when we had like a 9-month survival of an orthotopic heart. So we just had some celebration of that. So then, you know, we took these results to the regulatory agencies here, FDA, and say, is it good enough to start clinical trials? They said, no, it is not. You need to do some more non-human primate work, have some kind of consistency. We need you to do 10 more transplants with 6 of them surviving for 6 months. And then we will think of giving you the permission for clinical trials. But at the same time, we found out about a opportunity where FDA in special circumstances allows use of an experimental drug to save the life of someone who has no other alternatives left. So our cardiac failure team identified a patient, Mr. Bennett, who had no other alternatives. So for his non-compliance, he was not a candidate for human transplant. He had repeated heart arrhythmias that disqualified him for the use of ventricular assist devices. And so we also checked different hospitals to see if anyone else would take him as a heart transplant patient, but none of the hospitals, agreed to that. So this is a picture that showed that, we we started preparing a proposal for FDA. It's not just like a 2-page proposal to ask them that, can we use this experimental procedure to save the life of this patient who probably would have, died or had to be, kept on ECMO support, which he was on for last 40 days for a longer period of time. But there was no hope for him. So we submitted this application, and the FDA, and this was December 20th, and as you know, this is holiday period in the United States. So I mean, the FDA responded to us and asked for more details. So we went back and forth multiple times. So this is a board in my office which I have not erased yet. It shows you that the timeline on the right side, that how many times we went back and forth with the FDA. On the left, it shows how many permissions we had to get from the institution. So it was not only that FDA, but even the institution, we had to take multiple permissions and had to submit a lot of paperwork. So and the major barrier after, when we got permission on the New Year's Eve, but then the main issue was who will pay for this transplant, because so far it's been a month. We have already spent $1 million on this patient, and this will not come out of any insurance. So the hospital had to absorb this cost, and that was a difficult decision for the hospital in the time of COVID, where a lot of resources are being diverted to COVID patients. But fortunately, they finally came up with the money, and they allowed us to do this transplant. So these are some of the pictures of transplant. This is on the top right. This is my staff where we harvested the pig heart. The top picture is where the pig heart is harvested. It was put in this machine. It was still, this is the heart that was transplanted. You must have seen some pictures in the press, and it was finally transplanted and into Mr. Bennett, as you can see here. And you can see the function of the heart just after taking the cross clamp off. So this is so what we saw in this Mr. Bennett's heart when we took the Mr. Bennett's heart out. It was dilated several folds, more than we expected. So on the left is Mr. Bennett's heart. And on the right is the one after transplantation, the pig heart. So you can see that there was a huge disparity. The pig heart was smaller, so we had to modify the anastomosis of the heart. We have to make a smaller cuff of biatrial anastomosis in Mr. Bennett to accommodate the pig hearts shown here. So this was function on day 0. There were people who can appreciate it. Certainly Munir can. The function seems great. This patient stayed on ECMO for a couple of days because we slowly wanted to transfer the load on this heart. And after 4 days, we took the ECMO cannulas out, and this heart was supporting the rhythm. So here you can see that the same function at different time points, and the heart function continues to be very well. That was the short axis, that's like a cross section, and this is long axis showing the function of the heart. So we looked at the strain analysis, which is one of the tests to see if the the overall function of the ventricles are good, and they are equally contracting. The more red it is, the better the function is. So as you can see, a lot of red in the contractions. This for day 0, and this is like day 14. Unfortunately, today is day 29 of this patient. And so we have reached almost like a month after transplantation, and his heart function continues to be the same. We have not seen any signs of rejection. The one thing I would tell you that this patient was severely deconditioned. He was on ECMO for last 40 days, and he had not gotten out of bed for last 2 months before transplant. So all his muscles were severely wasted, and he could not even sit by himself. So the major challenge that we have now is not the heart. I'm very confident, based on all the research we have done, that this heart will not reject immediately. But because of the patient's condition, we had to reduce our immunosuppression significantly, because even at the time of transplant, his WBC count was very low. So we cannot have given the same amount of anti-thymocyte globulin to him, same amount of Rituxan to him. So we had to reduce the dosage. But one thing that I did not reduce was our anti-CD40, which I firmly believe is a major player in graft survival. So our main challenge now is not to keep this graft from rejection, where we are confident that it will continue to function well. Our main challenge is to fight infections in this patient because of immunosuppression and other areas. His renal function due to this surgery was depressed, so it's slowly coming back. So we have to support him with dialysis a little bit, but it will be a long haul. He will be in the ICU for a long time, and then there will go through long rehab before he will be discharged, hopefully to his home. So, this is just to show you that what we are monitoring in terms of immune surveillance and monitoring rejection. I showed you echocardiography, but besides that, we are looking at, immune mechanisms of rejection. There are different tests. The AlloSure and AlloMap are new genetical gene profiling markers that are being introduced into this system, which have not been used before in this kind of experiments. But we are using troponin, which is a reliable marker of rejection, and we are looking at different antibodies against the pig cells. So we think that we had learned a lot in a non-human primate model, but in a previous experiences where we moved from small animal to large animal model and had a lot of surprises, we think that there will be few surprises in humans also, because though it's close to baboon, but it's not the same. There are a lot of differences, and we expect them. One major concern that FDA had, and some of you may know of, is the transmission of viruses across species, and we have, although there is no evidence of any disease caused by these viruses that have shown to have infected human cells in petri dishes. One of them is the porcine endogenous retrovirus. This has shown to infect the human cell lines, but there have been some studies done in New Zealand where islet transplantation has been done from pig to human, and long-term monitoring of these patients shows that they don't have these kind of any disease, any porcine disease. But anyways, FDA was very strict, and their major concern was to monitor these kind of infections. So the patient had to sign a consent that he'll continue to be monitored throughout his life for these viruses. Not only the patient, anybody coming in contact with him had to sign a consent that they will if this patient develops some kind of disease, they will volunteer and come back and have them checked for the disease. So I mean, that this was the assurance we had to provide to FDA to get this permission. So where to go from here? So, and then the next big thing will be discharging Mr. Bennett from the hospital if everything goes well and he recovers well, which still, I would say, about 2 months away, because he will require a lot of rehab. He started his rehab a little bit. When we started, he couldn't even hold his neck up, but now he's able to hold his neck up and and sit properly. He wishes to go to the bathroom by himself, but he's not fit enough to do that by himself. One thing I didn't mention, then when we took the consent from him, which was a big thing, because it's a 4-page consent with everything possible explained to him. We never promised him a long-term survival. We told him that he could not. There's a possibility he could not even make it through the surgery, but he realized all that. We had 4 psychiatric consults done, 2 internal and 2 external, to determine his ability to give that consent. And then the ethics board reviewed those consents and approved. So it was a long process just to establish that he's mentally capable enough to give the consent to this. And he told us, just to let you know that he was mentally capable. He said that in response to this, when we asked for his consent, that, okay, once I have this heart, will I do oink oink? So he was, and now, I mean, he's pretty much in a condition that, he's a big football team Steelers fan. So he asked about how they are doing, and he knew that one of their quarterbacks retired. So I mean, he's mentally still doing very well. So it'll take like a while for him to discharge. But the FDA will not take this as an excuse for us to go and start doing this on a routine basis. They still want us to fulfill all the requirements of non-human primate studies and go through their proper route. There are other institutions after us who are desperately trying, and several of them in kidneys, to get similar permissions, but none of them have the data that we have collected over years. So it remains to be seen that who else can get the permission to do this one-off. But we require other institutions to participate, because just with one human experiment, we cannot generate the data that will convince the FDA to let us keep us in this process and let us do more more experiments like this. So this is a couple of pictures. This on the left, this is the first week after the transplant. You can see the patient is still, is reasonably attentive. And the next one is just last week when the other person in that picture is Dave Ayers of Revivicor, who was instrumental in genetically modifying these pigs. So, this patient was, talking. He has some difficulty talking because of, repeated intubations and stuff. But he's getting his voice back. On the left, the other person is his son. He lives alone. His son lives several miles away in a different city, so he doesn't come here very often. He just visited him for 2 days. So, I mean, this is something that that's not available or not in the culture of this country where I live. That he's been in the hospital for several days, but had no visitors from the family. So this was the only time that his son came in. With that, this is just a in my conference room. I made this to honor everyone who participated on this on the day of the transplant. As you can imagine, it was like a big show, and a lot of people participated. Just in the OR doing this transplant, every surgeon who had anything to do with this transplant was present in the OR. So it's a big thank to a large number of people who made it possible. With that, you've always heard this saying that xenotransplantation is the future and always will be. My goal is to change it to saying that xenotransplantation is present and it always will be.